but I'd like to now move on and have you bring back your information about the women's health issues once we hear from Dr. Evelyn Chang, who's going to tell us a little bit more about continuity of care for patients with complex conditions, also a health services researcher and internist in our VA Greater Los Angeles Health System. Thank you.
I'd like to thank the Academy for having me on today. I am a primary care physician and an investigator who has been studying complex high-need patients in the VA for the last 10 years. In my own primary care practice, I care for veterans who are homeless and also those with serious mental illnesses. So my opinions today are my own and do not represent those of the federal government. So just to talk about the terminology of who are complex high-need patients, there are a lot of different terminologies in the literature. There's multimorbid, high risk, high utilizer, super utilizer, but most often you see high need, high cost. And this is because 5% of patients account for almost half of healthcare costs. And we see this pattern in the VA and also outside the VA. Generally, these patients are characterized by an intense use of medical care and behavioral health services. They have social needs, including social isolation, health literacy, financial insufficiency, and unstable housing, and they frequently have multiple chronic medical conditions. Another way to think about this population is that while they have needs, they have high unmet needs, and some of these needs include access to and trust in a healthcare provider. And this population is also a high priority for VA national program offices such as primary care, geriatrics and extended care, and mental health. So I adapted this framework from a previous National Academy of Medicine special publication on effective care for high-need patients. But complex patients are very heterogeneous, as there are some potential buckets of patients that you see here. For instance, those with serious mental illness and substance use disorder, chronic pain, multiple chronic conditions, frail elderly, those with terminal illnesses. However, they tend to have also underlying similarities in their behavioral health needs, such as depression, anxiety, non-adherence, and also social needs, like the ones I've already mentioned before. And there are common challenges for complex patients. You see the patient level factors here, but today I'm going to be primarily focusing on system level factors, mostly mistrust in the healthcare system, which other presenters have also mentioned, and also multiple specialists, because these patients tend to have multiple specialists, which can present challenges in access to these specialists, as well as care coordination between these specialists. In terms of mistrust in the VA, only half of high-risk patients strongly agreed that they had a VA healthcare provider who they trusted. When VA primary care offered an innovative case management program for high-risk patients and also offered same-day access, whether it was by in person or by phone, trust increased to 61%, which was statistically significant. So we found that offering better access to the VA can increase patient trust in the VA. And it doesn't necessarily have to be in-person care. It can even just simply be telephone care. When you look at the data, it turns out that complex high-risk patients actually use more VA primary care services than low-risk patients. For instance, in terms of face-to-face primary care encounters, high-risk veterans have 2.5 times more face-to-face encounters than low-risk veterans. They have 4 times the number of telephone encounters than low-risk veterans, and also about 2 times the number of primary care secure messages than low-risk veterans. So when you look at traditional quantitative definitions, they have pretty good access. However, when you talk to patients and providers, you'll find out that complex high-risk patients desire someone who just simply answers the phone. So here are some quotes. When I was calling, it may have taken me 3 or 4 or 5 telephone calls to make sure I got feedback, that I get callback that I may not even get. Because what happens when you call the VA? They just put you on hold for 45 minutes, an hour, and then when you do get through, you have to get transferred to someone else, and you stay on hold there for indefinitely. Many high-need patients don't feel that the VA is going to help them. They feel that we don't care. They feel like providers and staff are just sitting around and doing nothing. While nothing is further from the truth, I can assure you that providers and staff are very busy. Another way to think about access might be having a connection to providers and the healthcare system. So this is a quote that I also really like. I really think that the greatest success story is just the human touch, and that now they're connected to providers. These patients feel so happy that they have someone that they can call, that's going to answer the phone, that's going to call them back, that's going to look at their blood pressure reading and say, this is good, this is not, and this is what you do. So here are some potential strategies to improve access overall. We know that patients value contact with a continuity team and the healthcare staff who they know and they trust. And we have call center representatives their job is to respond quickly to telephone calls, making sure that they connect with the primary healthcare team is important so that the follow-through can take place. Also, email and phone communication may be sufficient for these veterans, and video visits actually may not be necessary. Also, developing workflows to respond in a timely manner to patient phone and email messages is important. And so this is where in primary care, for instance, having the nurse care manager and the front office staff can play a critical role in helping with triaging these phone and email messages. And lastly, creating a more flexible clinical grid for healthcare staff that combines in-person, phone, and video visits rather than emphasizing exclusively in-person care. So right now in our current EMR, we only have a grid for in-person care. And this may be possible when we move on to Cerner as a new electronic medical record, but currently, for instance, if I have a patient who requests a phone appointment or a phone visit, and my in-person schedule is completely booked, which it usually is, then I have to call the patient over lunch, or I just hope for a no-show when I'll be able to return all the patient phone calls. In terms of strategies to improve access to specialists, this is important because complex patients tend to have a lot of specialists who can be very difficult to contact. So primary care can facilitate access to specialists as part of their care coordination function. And so Hal Yee yesterday talked about e-consults, which can expedite specialty care beginning in primary care. And this is very valuable because we can begin workup in primary care, and asking some of these curbside consultations can actually obviate the need for some of these patients to be seen in primary care as well, in specialty care. Also, having decision support and an EMR order set that helps to work up common specialty problems can also help to expedite specialty care, beginning with the workup in primary care. Also, it may be that they may not even need to see specialty care. So for instance, at my healthcare system, Greater Los Angeles, we have decision support for hypogonadism, for high PSA or prostate specific antigen, so that we can work these up before we have to refer to the specialist. Also, our primary care nurse care manager plays an important role in notifying patients that they have a specialty appointment, also reminding them, and also even scheduling them if they've been having a problem with scheduling and coordinating themselves. Also, creating a directory of backdoor extensions for primary care or other providers to specialists can be helpful in case real-time consultation is necessary. Also, teleconsultation with specialists for veterans who live in rural areas is also very important. So one great example of this is actually the telebuprenorphine consultation. So rural areas have been similarly affected by the opioid use disorder and opioid epidemic as urban areas. However, rural areas do not have access to the same addiction services as urban areas do. So having an addiction specialist who's able to provide teleconsultation to rural veterans can actually improve outcomes. Also, lastly, we can refer to specialists outside of the VA as in the Mission Act, which Dr. Matthews talked about yesterday. The VA Mission Act, briefly, was passed to provide high quality and timely care to veterans and restore trust in VA by improving access to care through the community care program. There are trade-offs, however, of faster access to the community. While it offers faster in-person access, coordinating care presents its own challenges, and no evidence-based practice yet exists to coordinate care with other healthcare systems except for health information exchanges, which provides real-time visualization of other progress notes. So we may need to weigh the benefits of faster in-person access versus improved care coordination, care continuity, and potential for comprehensive treatment planning for high-risk veterans. So I also just wanted to mention quickly about how COVID-19 might be affecting high-risk patients. So we know that patients fear acquiring COVID-19 from the healthcare system. So we're seeing increased mortality at home. We're seeing delayed presentations to the ER and the hospital. And also paramedics were not bringing patients to the emergency room. So for instance, in my own practice, I had a patient who couldn't walk. The paramedics didn't want to bring him in. Also a patient who presented with slurred speech, and the paramedics didn't bring him in. These are back in March when COVID-19 was pretty early. There's also fewer in-person visits to prevent COVID-19 transmission. So this is the wonderful thing. It's been able to increase virtual care, also by doing telephone and secure messaging and video. Also, it's increased access to primary care and specialists. So I have a patient who hasn't been able to see a mental health specialist for years because she is the primary caregiver for her elderly parents and is unable to come into the VA. However, and the only thing that we could do to arrange for mental health care was for her to come into the ER on the weekend. However, because of COVID-19, mental health finally was able to offer telephone care, and she was able to talk to a mental health specialist by phone and get the care that she needed. And also, it has exposed the digital divide, as Donna was mentioning, because some patients may lack the equipment or may not know even how to use their own smartphone. So how do healthcare systems weigh the risks and benefits of seeing high-risk patients in person? Again, patients may lack the equipment or know how to use it, but patients may also need a physical exam, for instance, if they had acute pain, or they prefer being seen in person. So just to summarize, despite their heterogeneity, complex high-risk patients share common challenges, particularly mistrust of the healthcare system. And high-risk patients already have access, but it does not seem to meet their needs. And to these patients, access simply means feeling cared for or feeling connected to a healthcare provider. So we would suggest that VA healthcare providers should identify their high-risk patients and develop workflows to respond in a timely manner to phone calls and emails, and offer multiple modalities of care that fits with veteran needs, preferences, the clinical situation, and maximizes safety. And while these things just sound so simple and so basic, the consequences for not following through may be magnified in this vulnerable patient population because they may not trust to come into the VA, they may not think that the VA providers care, they may not want to come into their scheduled appointments or not want to present to the ER, or maybe even want to go to an outside facility. And so I think if we were able to accomplish even these most simplest tasks, the veterans would want to choose the VA. So thanks again. And I just want to acknowledge some of my collaborators over the years. So thank you.
Thanks so much, Dr. Chang. You've raised many issues about the complex population that is served by VA.